If I determine they have a vagus nerve problem, I'm going to treat that with vagus nerve exercises and frequency specific microcurrent because I want the vagus nerve to go fully functional.
I want to talk about your supplements.
So I'd say curcumin is a number one thought in terms of neural inflammation. DHA and omega-3, but primarily the DHA component, I think is really important.
One needn't actually have a head injury to have a head injury. You could have long COVID. You could have Lyme.
Now what I've been seeing in the past number of years is hypoxia where you wouldn't even expect it, where dysfunction where you wouldn't even expect it.
Hi, listeners. New Frontiers in Functional Medicine has been going strong since 2015. With almost 200 episodes and over 2 million downloads, my goal is to bring you the best minds in functional medicine, epigenetics, and longevity. I want actionable insights for the clinician and non-clinician alike. You can access episode transcripts, summaries, research citations, and more over at drkarafitzgerald.com, where you can also find information about our clinic and sign up for the e-newsletter as well. Thanks for supporting this podcast with your likes and your honest reviews, by sharing this with your colleagues, with your family and friends. Thank you also to our sponsors. These are companies that I trust, that we vet carefully, that we use in clinic practice, and that I use personally. Thanks to our Diamond Level sponsors. For over 40 years, the foundation of Biotics research has been innovation and quality. Their goals remain unchanged: innovative ideas, carefully researched concepts, and product development with advanced analytical and manufacturing techniques. Biotics nutritional products are superior quality and effectiveness. They are available exclusively to the healthcare provider. Find them at bioticsresearch.com. Precision Analytical, creator of the Dutch Test, is launching a new educational program this January. They are offering evidence-based training on key topics like hormone metabolism, interpreting Dutch test results, and therapeutic strategies, including hormone replacement therapy, all aimed at improving patient outcomes. Become a registered provider to gain access to an expansive education hub with ongoing content, including webinars and case studies. Visit dutchtest.com/courses to get started and grow your practice. For over 35 years, patients and clinicians have trusted Integrative Therapeutics for their dedication to quality, potency, and accuracy, and for bringing us exclusive products backed by science. From sourcing premium raw materials to their meticulous manufacturing processes, they prioritize consistency, efficacy, and safety because our patients deserve nothing less. Find them at integrativepro.com. That's integrativepro.com. Thanks to our gold level sponsors. Timeline, fueling cellular energy for a lifetime of healthy aging. Find them at timeline.com. OneSkin, skin age reversal technology. Find them at oneskin.co. That's oneskin.co. Hi, everybody. Welcome to New Frontiers in Functional Medicine, where we are interviewing the best minds in functional medicine. And, of course, today is no exception. If you're on YouTube, you can see that I am sitting next to, on the virtual space anyways, Dr. David Musnick, a longtime friend and colleague from the Institute of Functional Medicine. We're going to be talking about his approach, a functional approach to traumatic brain injury today. You'll have lots of notes. He's brilliant, he's funny, he's cutting edge. So let me give you his background and we will jump right in. Dr. David Musnick, MD, has been in practice for over 30 years. His field of expertise includes functional medicine, sports medicine, and internal medicine. He's a leader in edge sports medicine treatments, which include prolotherapy, scar therapy, low-level laser therapy, frequency-specific microcurrent, and chronic pain management. He's also been working with TBI patients in particular for over 20 years and published a great chapter in Oxford University Press, Integrative Neurology in 2020. We'll be touching on some of that content as well, and we'll link to it in the show notes. He is on faculty, as I mentioned earlier, at the Institute for Functional Medicine for many, many years. He teaches sports medicine at Bastyr. He's faculty at UW, sports medicine and orthopedics. He's also author of multiple textbook chapters, including this Oxford University Press chapter, and he is the author of the book Conditioning for Outdoor Fitness. Dr. Musnick, welcome to New Frontiers.
Thank you.
All right, so let's jump right into traumatic brain injury. First, let's just talk about a standard of care approach.
Well, the standard of care approach is someone has a concussion. We probably at some point want to differentiate what's the difference between a concussion and a TBI. But someone has a concussion, and so they go to the emergency room, if they do go to the emergency room, and then the main job there is to rule out a brain bleed. So they'll probably do a CAT scan to rule out a brain bleed. And oftentimes the ER docs will tell the individual or the parent of the individual, okay, have them rest, literally have them rest. And if they have headaches, to come back, but if they have any major symptoms, go to a neurologist. So if they go to a neurologist, the neurologist does not actually work off a pathophysiology model of what actually goes on in the brain. What they do is they just label it like, yes, you had a concussion, or yes, you have post-concussion syndrome, or label it as, yes, you have TBI, but that's past the time of post-concussion syndrome. And then they will either, refer them for speech therapy or not, and then they'll have them come back in a month. And so I've had so many patients say, what is this come back in a month program? And they literally go back every month and they just literally document their symptoms. Now, in the sports arena, it's a slight bit different because they want to make sure you're outside the 2-week zone, because if a person gets another concussion within 2 weeks, they can have fatal brain edema. And that's why there's been all this business about let's decrease the risk of another concussion within 2 weeks because of brain edema. But then there's specific types of testing that are done before they might let a person who's an athlete go back into a contact sport. But basically, the pathophysiology is not addressed.
So, okay, thanks for that overview. Let's just define a couple terms since you brought them up. Concussion, post-concussion syndrome, and traumatic brain injury. Let's just tease them out.
Okay. So a concussion can be a direct head injury, or it can be indirect, because you will hear about people that have a whiplash injury in an auto accident, or they fall but they don't hit their head, and then they have concussion type symptoms. In other words, it's a mechanical stress to the brain. And sometimes people report seeing stars, they'll report lightheadedness, and then they can start reporting what would be called post-concussion syndrome symptoms. And the list is pretty long, but it starts with fatigue and sleepiness, where people will literally want to sleep for 12 or more hours for days on end, headaches. And I do want to differentiate that headaches that can also be related to the neck. So they can be related to the head injury, but people have to look at the upper cervical spine. It's almost impossible to get an actual head injury without injuring your neck. So I would say there's sort of a crossover between upper cervical spine injury and post-concussion syndrome symptoms like headache, nausea, dizziness. That's interrelated with upper cervical injury as well. So sometimes it's appropriate to get an open mouth x-ray, because remember, a regular 2-view x-ray does not show all of the upper cervical spine. And then there could be visual issues, and there could be nausea, and as I said, fatigue and sleepiness. Those are the most common things. Post-concussion syndrome.
What's the timeline for the post-concussion syndrome?
Well, the post-concussion syndrome, usually starts right away. Mm-hmm. And then I've seen probably more than 500 concussion patients. So I'd say, even on the basis of my own on my own experience, usually they're either gone or they're still there. It depends if they get treated for this, because like I said, most of the time they don't get treated for it. And it depends. If they see a chiropractor, they're going to get treated for the cervical malalignment issues. If they see someone who could deal with the craniosacral or the cranial things, they'll get treated for that. But, they can also have vagus nerve injuries. And so, you'd expect most post-concussion syndrome symptoms to be gone by 6 weeks. But the definition of TBI, especially MTBI, which is mild TBI, is that it's brain-related symptoms, specifically, not headache, not nausea, not dizziness. It's brain dysfunction in any number of brain regions, whether it's, the forebrain, the midbrain, the hippocampus. It's specific brain region dysfunction. So I think it's very important that anybody treating this or dealing with this has a way to assess brain regions. Like there's a really good 3-page questionnaire that Datis Kharrazian developed actually originally. And it's called a brain region localization questionnaire. And it's excellent because in about 10 to 15 minutes, someone can answer all the questions and you can look and see what brain regions are actually dysfunctional in TBI.
Okay. All right, well, we'll link to his page, or if we can access the document, we'll link to that. But folks, we'll chase it down for you and we'll put it on the show notes. And so post-concussion syndrome, so the concussion happens, the acute stuff might be ruled out at the emergency, or brain bleed ruled out at the emergency department, but then they are in or transition into post-concussion syndrome, which you described. And then TBI is specific to the brain, and that's going to kick in maybe immediately, I would imagine, or later. And this is what can keep going until there's a holistic approach.
Yes. Yeah. So I would say, the term TBI or MTBI, which means mild TBI, is usually used as a diagnostic term. Either you're billing insurance or you're not, but it's used as a diagnostic term. And then the term concussion can be used, or post-concussion syndrome can be used. But when you're really working, especially if you're working with someone who's past 10 to 12 weeks from the event, then you're talking primarily about, mild TBI in regard to the brain dysfunction that you would find from doing a history and from doing the brain region localization, as well as a physical exam, because you do have to do a physical exam.
Let's move into the pathophysiology, and because it's extensive, and there are areas in imbalance that we in functional medicine have thought about for the most part, but it's extensive. So I want to talk about that. And I'm also curious, David, if you can layer in the different brain regions, what might be lighting up of the various mechanisms given a particular region, just as it comes to you. We don't have to be super exhaustive.
Do you mean in terms of what might, so let's just take an example. A person could have difficulty creating words. That's Broca's motor speech, but they could have difficulty finding words. And so that could be in the parietal and temporal areas. So, just getting people to answer questions about these things will categorize these brain regions. But the other thing that's really important, Kara, is when you take a history of a person who had a head injury, you want to find out, okay, what part of your head did you hit? Like, let's say someone fell backwards and hit the occipital area. Well, then you would expect potentially an injury to the cerebellum, and you might expect balance problems or coordination. But the interesting thing is there's often problems like on the other side of the brain. So you got to think, okay, there's a problem maybe on the occipital region and the frontal region. But what's also interesting is in the anatomy of the skull, the temporal regions of the brain, because of the bony anatomy, are often impacted in almost any concussion.
Okay, let's talk about the physiological mechanisms. They're extensive.
They are. And it's totally fascinating when you learn that all these mechanisms are potentially going on and they're being completely ignored. in a conventional approach. Either someone sees a primary care provider, the pediatrician, the neurologist, they're all ignoring it because they're working on a model which you're familiar with, which is label it and then think of one thing, for it. Label it and
they confirm the individual is going to survive, and if not, yeah, I mean, or if they need to be hospitalized, and they're in coma, et cetera, et cetera. There's a direction. There are tools in the toolkit for those more severe head injuries.
Right. But for the vast majority of people, they don't have a brain bleed. They don't need to be hospitalized. They don't need an operation. They need this approach that you and I are going to be talking about, because if they don't get this approach, and this is really important before we go into pathophysiology, is that there's a concept of the actual mechanical shearing of the neurons and the synapses and the synaptic anatomy, which damages it. But then there's something called secondary brain damage, which is if the pathophysiology is not managed, there'll be more loss of neurons and synaptic networks than there needs to be. And sometimes, believe it or not, the secondary brain damage is as much or more than the initial trauma, which is, to me, it's been fascinating ever since I studied this. Okay, so you want to go into pathophysiology. Okay, so, and then interrupt me if you want more details on something, because I definitely want to give more details on neural inflammation and certain things. And neuroexcitotoxicity is really interesting. So you get the mechanical shearing forces, and then you have what's called brain edema. So you actually have increased fluid in the brain, you have brain edema, and then we have damage to the blood-brain barrier. And I do want to talk about that a little bit more. But I just want to list these things right now so people can see all these things that they potentially have to deal with. So damage to the blood-brain barrier, and then eventually you can have what's called blood-brain barrier permeability, which is similar to, tight junction protein issues in the gut happening in the brain. Okay, then you have relative hypoxia in regard to damaged areas. But now what I've been seeing in the past number of years is hypoxia where you wouldn't even expect it, where dysfunction where you wouldn't even expect it. And I'm starting to look into this red cell viability issue and what's happening to our red cells in terms of oxygen delivery. Okay, and then you have...
It's a teaser. You're going to have to circle back to that. I'll just make a note.
That's fascinating. And then you have mitochondrial dysfunction, which is quite significant in brain injury, with decreased ATP production, damage of mitochondria. And then you have oxidative stress, which damages mitochondria, the blood-brain barrier. So a lot of these things are interrelated. Something that's also fascinating is protein folding abnormalities. And then you have an issue regarding neurogenesis and synaptogenesis, which I would say are pathophysiological pathways, because the clinician needs to figure out, well, how do I enhance neurogenesis? How do I enhance synaptogenesis? And then you have other issues, and one of the subcategories of brain inflammation is microglial dysfunction. We'll probably talk about that. Hormone, then there's other issues that can occur, like the pituitary can actually get damaged. And so you can have pituitary dysfunction, sex hormone dysfunction. You can even, and I've seen this, have dysfunction of antidiuretic hormone, where people start having frequent polyuria because they don't have enough antidiuretic hormone. And I've actually seen that in long COVID, but I've been seeing it in concussion patients. So the other issue which gets interesting is in pathophysiology really comes to the question, okay, what kind of brain did someone bring into this concussion? Was it a normal brain? Or was it someone that had prior concussions? Because if they had prior concussions, they lost neurons already. They have what's called primed microglial networks. And so, or do they have mold biotoxins? Do they have Lyme? What else did they have? Heavy metals? Because that's something that needs to be dealt with in regards to the more chronic case. If they're slow to heal or they're not getting as as better as you think they should. You have to start dealing with those other functional medicine factors.
So if somebody comes to you who's a football player, maybe they played college, pro, or an athlete in high school where they've had repeated head injury, I think they're vulnerable to more head injuries. And correct me if I'm wrong, that one can beget another, but they also have some of that residual damage, especially if they're only working within the conventional arena that's basically just making sure they're alive.
Right. You brought up an interesting point because, say, someone has multiple head injuries. So you can think that each head injury someone's had, they've lost certain neurons and they've lost certain synaptic networks, and they've got what's called prime microglial populations. So I've had patients that had, say, 2 concussions that were worse than the most recent one, but now they're having big problems from the most recent one, because it's sort of like, okay, you've already had a decrease in brain reserve already. So this is a key concept, brain reserve. And brain reserve is related to each area of the brain, how much reserve there is, because below a certain line, if you want to draw an X and a Y axis, you're going to have symptoms. But you have to have lost a certain amount in an area, say Broca's motor speech, before you have trouble speaking, right? So you have to have lost a certain amount there. But a lot of people, depending on what's going on in their brain, they're hovering right around the line of brain reserve. So they're just a little bit above. Then they get a little head injury and they drop below, and they say, why am I having so many symptoms? That's because they didn't come into it with a normal amount of brain reserve in that area of the brain. And I'm seeing this even more. I mean, you do see this more in older people. You see this more in people that have had concussions, but you also see this in people that have had other brain insults. Because, I consider long COVID in a lot of people a brain insult, and then the post-vaccine injury a brain insult. So, mold biotoxin issues or Lyme, it just depends what they're coming in with in terms of how much brain reserve they actually have. So we might hit another pathophysiology pathway, because there's about 14 of them. And I'm not looking at my slideshow right now because I'm on my PC.
We made you get on your PC. That's so funny.
I had to get off the menu.
Can you just speak a little bit, because I know it's in people's brains, a little bit about CTE and where that falls here?
So CTE stands for chronic traumatic encephalopathy. So that is a diagnosis in a person that's had multiple concussions. Usually, in order to make the diagnosis, the person has had multiple concussions. It's usually associated with hippocampus and medial temporal lobe problems, memory issues, a lot of brain dysfunction, but a lot of issues regarding emotional instability, anger management, depression. Oftentimes, people are suicidal. There was a lot of notoriety regarding this. There was a movie about it was called Concussion, actually, but there's been a number of professional athletes that have committed suicide. And so I think it's important for people to understand that if you're dealing with someone that's had multiple concussions, that you've got to think about this, and then you really got to apply everything we're talking about to this, because it can be treated. I mean, I've treated a bunch of these patients and I've gotten them to pretty good shape. But there's no drug for it. You have to use this pathophysiology approach and really ask yourself some questions, But in those people, you have to deal with limbic system issues and stabilize the emotional stuff so they don't commit suicide.
I want to hear some cases from you around that. It's funny, we're digressing a little bit, which we should be, but we'll circle back to some cases. But let me I want to just point out, I just want to underline something you said that was really, I think, crucial to the conversation. One needn't actually have a head injury to have a head injury. You could have long COVID. You could have Lyme. You could perhaps layer on, ApoE4. I mean, you could have.
Yeah.
I mean,
But let me differentiate this, because I think it's important.
Yep.
So I would not. So I want to use the term head injury for a mechanical issue.
Okay.
So you can have a direct head injury, you slip and fall. I've had kids where someone kicked a soccer ball in their head, to their head. I had a guy today who fell off a surfboard one time and hit his head on a rock. Another time the surfboard hit him. So that's a direct mechanical insult that leads to these shearing forces, and then all the pathophysiology that I talked about. Then you could have someone that has an indirect head injury, like a motor vehicle accident with a whiplash, and so you can have people that did not have a direct head injury complaining of head injury symptoms, post-concussion syndrome, that. Now, if you have someone who has something that causes a brain infection or brain inflammation or brain toxicity, I do not call that a head injury. I call it a brain insult. But some of these pathophysiology mechanisms still apply, like microglial, morphology changes and the damage to neurons, the need to induce synaptogenesis and neurogenesis. There is a big overlap with these things. And some of the patients who hit their head have some of this other stuff going on, or I've had people that stopped my program too early. And I'll tell you what too early is. And then they had a virus, and then the head injury, quote, head injury symptoms came back because it appeared that the virus was affecting the central nervous system as well as their body. And they went into what I call, below that line that I was talking about, where they go, oh yeah, I'm having symptoms. That's why I finally decided with my patients, I said, you're adhering to the brain diet that I developed, and you're taking these supplements until 3 months after you don't have any brain-related symptoms. And when I started putting that into place, I wasn't having people relapse unless they had a new head injury.
And this, well, I want to go into the protocol, but you could use this for a brain insult or a brain injury. Would you say that's correct? You could use the protocol that you'll talk to us about?
Yeah, but what I might do is so what I would say, and this is fascinating. You probably know that I started developing this in 2016, but for about 15 years before that, I was treating a lot of brain injuries referred to me from the ER. So I was piecemealing things together that were, quote, integrative or functional. But, that when you start looking at the brain insults, you can categorize some of this stuff as what's the pathophysiology of, quote, long COVID? What's the pathophysiology of, aluminum toxicity or Lyme or whatever it is? There's some crossovers. And also the key point I want to make for any clinician trying to manage these people is if someone isn't considerably better within 12 weeks of the original head injury, you got to start looking at what I call these comorbidity issues, because you may have an issue with spike protein in the brain. You may have an issue with heavy metals. I mean, you just got to decide what it is and what to go after. Besides, we'll talk about the relationship of insomnia and sleep problems. But one thing I want to say that's fascinating is that there's a lot of information that I've uncovered here that's in tune with the Bredesen approach to cognitive impairment, but goes beyond it in some ways, because I've adapted my program to patients with mild cognitive impairment and to early dementia, and it works considerably, helps them. So there is a crossover with that too.
There's plenty of clinicians listening to this, and there's regular people who probably want to bring this to their clinicians' attention. In terms of a good history, what are you using? Sort of a modified functional medicine intake. We'll have IFMCP people here, and they'll have access to some of those tools. Is that a resource, or have you developed any? Is there anything that you're willing to share on our show?
Yeah. So I always do the brain region localization questionnaire, but I'll just sit there and ask the parent or the patient, I want the mechanism. I want to know the mechanism. If it's a car accident, all the mechanism issues. What way did your head move? If it's falling and hitting your head, what part of your head did you hit? Yeah, we use the IFM, initial questionnaire, but I will tell you this: a lot of patients, if they had a head injury and it's not their parents filling it out, they can't even fill out a lot of those forms. There's too much of it.
So you work with them on it.
Yeah, I'll still work with them because some of these people, you just got to get them in because they have so much brain fatigue, which you know what that is. It's like they can only use their brain for half an hour and then they're done. It depends on their brain energy as to how much of these forms they can fill out. I like to know what the pre-existing comorbid conditions are because then I need to know if I got to start dealing with them right away or because we talk about staging and a timeline. What are you going to do? How are you going to introduce things? So I like to know about that. But in general, I want to know the mechanism of injury from the person, from the parent, whoever it is.
Yeah, so I think in these cases where there's, pretty severe trauma, they need a support person, just like when you're working with somebody who's got, cognitive impairment of any extent,
Right.
There needs to be.
The other thing is if they have a video, I want to see the video. I saw the other week, I could not believe this, a 14-year-old boy who was, kind of small for his age, an ice hockey head injury, where some kid, and I think the kid that did it was like 1.5 times his size, came up and pushed him in like this, and his head hit the glass. He fell to the ground, then he hit his head again. I mean, talk about a mechanism of injury. I mean, I could see it directly because he had 2 hits to the occipital areas. So certainly if someone has a video, you want to see that too. You want to see the mechanism. The main thing is I want to know how severe it is. I want to know how aggressive I need to be. And I want to, be able to impress upon people how important it is to do this program.
I think, and we'll grab folks, we'll hound Dr. Musnick for any tools he might send our way, and I'll put them on the show notes or any papers. We'll link to the book that he's got a chapter in. But the other piece too, and I guess this is why I'm hearkening back to the intake questionnaire that that we created at IFM, is that it's going to cast that wide net of comorbidities, as you said. So we're going to be thinking about vaccines. We're going to be thinking about incidents of COVID or Lyme disease or mold or, toxin exposures. We're going to be looking at diet, like all of those secondary pieces. We'll be looking at family history and whether there's a pattern of dementia or neurodegenerative conditions, ApoE status. So those two. And if you're working with an individual who's too damaged to relay a history of that depth, then you either hold on it or you talk to their support person.
Yeah, but you brought up some good points. And I would add a few other things. I would add, okay, what do you do for exercise? Because sometimes they're going to start doing stuff that could re-injure themselves. So I always want to know what sporting activities do you do? What contact activities do you do? What kind of competitive events are coming up that you want to do? And then I take a really in-depth electromagnetic field history, because there's a lot of information on how electromagnetic fields damage the blood-brain barrier. And so I want the history to know how, then I'm going to advise them on how to mitigate the electromagnetic fields. I also want to know their dietary history.
When are you going to be flagged that EMF has played a role in what you think is a blood-brain barrier pathology?
Well, so this is the way I do this is I make EMF suggestions to all these patients because I don't know that I'm going to be able to diagnose, okay, your blood-brain barrier is also damaged with this, except to tell them there's studies that show that EMF, and remember EMF is broken down really into 3 parts: radio frequency, electrical, and electromagnetic fields. And most, but not all of the EMF is the radio frequency from the cell phone and from Wi-Fi. So in general, because I know that everybody's using their cell phone, I will make recommendations. And I say, look, these recommendations are called brain protection. We've got to protect the neurons and the connections that you have. We got to protect the blood-brain barrier. So I want you to adhere to as many of these as you can. Keep the cell phone away from your head. Don't sleep next to a cell phone. You would be surprised how many people sleep with the cell phone 2 feet away from their head all night long, and then turn the Wi-Fi router off at night because Wi-Fi is damaging to the blood-brain barrier and directly to neurons. And so I basically give everybody these EMF mitigation suggestions. And there's some patients that are really struggling with their head injury symptoms. I will send a technician to their home to do the measurements and then give even more specific EMF mitigation suggestions. These would be the more severe people.
And what are some of those EMF mitigation? Like, would you do, I think, is it like the various cages we can put around our Wi-Fi? I mean, like, what are you recommending?
Well, there's actually there's something someone can wear that creates a scalar field. So that's one thing. I don't know if I can mention the name of companies, but there is a company that makes a device that you can wear that creates a scalar field. And the interesting thing about that is that it will not change the readings that a technician does, but it will decrease the biological harmful effects of the EMF and radio frequency that person's being exposed to. So I might recommend that to somebody, either a room version or something they wear. I think the little things that you put on cell phones, I don't think they do that much. I just want the cell phone as far away from them as possible. I show them this, and I don't want them wearing any Bluetooth in their ears. Like, I don't want any Bluetooth devices. So I say everything has to be wired. And then if you want an earphone, it has to be an AirTube earphone. So it goes on their note. All these suggestions just go on their note to please do these things. And if it's a kid, the parents have to, of course, get involved with this.
Before we move into your program and some cases, I would like to discuss some cases. I just want to talk about gastrointestinal involvement and, the microbiome involvement in head injury.
So it appears that even within 24 hours of a moderate significant head injury, that there's going to be microbiome dysecology and dysfunction. And, I don't know that you characterize it as IBS or SIBO or something like that, but there's definite changes in the microbiome. It's been shown, it's been proven. And there's a number of possible mechanisms, but one of the mechanisms is via the vagus nerve. And one of the mechanisms is just via the brain. But, so I do think it's also important to test people for vagus nerve dysfunction by see how the palate elevates, see if they gag. I've been seeing people the palate elevates, they don't gag at all. But I've been seeing people the palate doesn't elevate and they don't gag. They definitely have a vagus nerve dysfunction. So I think we have to check for that. And then, it seems like intestinal permeability will change. But, the funny thing is, and this, it's like how many people have normal intestinal permeability? So they might be going into this with abnormal intestinal permeability anyway. But it seems like there's been some information that intestinal permeability can get worse or start acting up. And that, like I said, there's a number of mechanisms. So what I usually do is I ask people like, okay, how's your digestion and your gut been since this event? Are you having any gas or bloating? Are you having normal bowel movements? Try to just figure out if I could see if there's any, dysfunction thereof. And if I determine they have a vagus nerve problem, I'm going to treat that with vagus nerve exercises and frequency-specific microcurrent because I want the vagus nerve to go fully functional.
And, again, for our show notes, my team will grab your contact information. Do you ever do clinicians? Are clinicians able to shadow with you, or you're taking patients?
Oh, I'm taking patients. Yeah, if someone wants to come to my clinic in Eagle, Idaho, they can shadow me.
Well, you've got a lot to offer. You've been working on this arena for a long time. Let's talk about the program you designed, when you first started and kind of some elements of it.
Okay, so it's really important to look for orthopedic musculoskeletal injuries and then deal with that, because if someone has pain, you have to deal with that. So, and I find that fairly common. So I'm not going to go into how to deal with that, but it's very important because sometimes people develop sensitization of the actual nervous system. that changes, and then they can develop worsening pain, more chronic pain. You have to assess sleep and get people sleeping a minimum of 8 hours, because 6 or less hours is associated with blood-brain barrier permeability and actual brain inflammation. So you got to get people sleeping. And I can go into that if you want me to, but you got to assess that. And then you say, okay, where's this person? Because I've broken it down into acute, subacute, and chronic. And then I say, when you get into the chronic version of it, you then have to break it down even more. Chronic with significant comorbidities like we've been talking about, mold biotoxins, Lyme, co-infections, reactivated Epstein-Barr, all of it, post-vaccine issues, long COVID issues, whatever. So either chronic with no comorbidities or chronic with comorbidities that you have to address. And then I say, okay, what stage are they in? So when I give, slideshows on this, I actually show slides of, okay, here's the acute stage. This is what you need to think about. You need to think about edema. You need to decrease edema. You need to think about oxygenation. And what's also interesting about the acute stage, you might say the acute stage is anywhere from 2 to 5 days. A lot of people wait for hyperbaric oxygen until like 3-4 months, and they're not doing well. And they say, oh, maybe we should add this. No, you should do it early, because issues regarding brain hypoxia is an earlier issue. So if in doubt, hyperbaric oxygen, which has a lot of studies in regard to TBI, can be very helpful. So in the initial stages, we're trying to limit bleeding. There's actually frequency-specific microcurrent FSM approach to the acute stage versus the subacute versus the chronic. And I can talk more about FSM because it's extremely valuable. It's changed my practice starting in 2009. But since then, I've designed probably about 25 programs to address different brain regions and all that.
Healthcare providers have long relied on Dutch to uncover the underlying causes of hormone-related issues, offering actionable results supported by peer-reviewed research. In research highlighted in the November 2023 edition of the journal Menopause, dried urine testing was validated as an effective method for monitoring hormone replacement therapy. This pivotal study is just one example of the rigorous research that forms the foundation of Dutch's approach, empowering providers to make informed decisions with certainty. This study underscores Dutch's commitment to evidence-based medicine, equipping providers with the confidence to navigate complex treatment decisions. Explore the world of Dutch testing and our steadfast dedication to scientific integrity at dutchtest.com/research.
Dr. Fitzgerald deeply researched how to age well, and a clinically studied formula that can do wonders for your aging process is Qualia Senolytic. Senescent cells, or zombie cells, accumulate in your body past age 30, wasting your energy and nutrition and contributing to accelerated aging. Qualia Senolytic combines 9 vegan, plant-derived compounds to help naturally eliminate senescent cells to help you feel years younger. Try Qualia Senolytic at qualialife.com/Cara15 with code Cara15 for 15% off. That's Qualia Senolytic at www.qualialife.com/Cara15.
In the subacute phase, which might be 5 days to about 6-7 weeks out, then you really got to address the blood-brain barrier. You got to address neural inflammation. You got to address neuroexcitotoxicity, mitochondrial dysfunction. I mean, those are big deals. Then you need to introduce what I would call a healthy brain plan in terms of the diet. Then, in terms of the certain flavonoids that I can talk about, but there's I like to introduce things they can do with diet, supplements, the microcurrent, and other things, and brain challenges. And so what I would say is that you don't start thinking about neurogenesis neurogenesis means actually nerve stem cells migrating from places in the brain where they exist to the injured areas. You don't really start thinking about encouraging that too much, probably until about 6 or 7 weeks out. Then you really got to think a lot about, okay, neurogenesis, synaptogenesis, how do I encourage that? How do I get the survival of these nerve stem cells? How do I encourage synaptic branching and survival? But during the whole process, you've got to be thinking about microglial cells and neural inflammation in regard to that. And then in the chronic phase, you've got to start thinking more about hormones and some of the things we said that could go on chronically with the comorbid factors.
Talk to me about interventions for each of these stages. You don't have to go through your whole program. I'm sure that it's massive, but just
so let's just say you're
edema.
lucky enough to see someone within the first 2 to 3 days.
Yeah.
Which many people are not. I used to get that because I get them right from the ER. I mean, the next day, 2 days later. So, and I do homeopathy in my practice, and I studied in the French School of Homeopathy because for a long time I saw the utility of it in terms of sports medicine. Then I started using it in terms of brain stuff. So I would say you get someone early, besides, of course, ruling out a brain bleed, then you want to start arnica, like, Arnica 6C, 5 pellets under the tongue every 15 minutes for 4 times, and then every 2 to 3 hours. It will actually limit probably brain hemorrhage. And then if I see someone early, I'm going to start the acute brain protocols with frequency-specific microcurrent. And then I say you've got to limit things that might inhibit platelets too early because you don't want more brain bleed. You have to start limiting neuroexcitotoxicity. So I tell people, you're off your calcium supplements actually during the whole period of time we're doing this, because I don't want the NMDA receptor issue going with the excitotoxicity. So I talk to them about limiting neuroexcitotoxicity. I see people coming in chewing gum. I want to know what the sweetener is. We talk about aspartame and limiting that. I usually put them on magnesium threonate right away. Otherwise, I'll put them on a different type of magnesium, but the threonate seems to be better for the brain to limit neuroexcitotoxicity. We talk to them about how to avoid hidden sources of MSG, but then get into pretty quickly about, how to sleep, how to get enough sleep, and then how to modulate neural inflammation.
Let me stop you. So MSG for the glutamate and the excitotoxicity. Sleep. How do you get? You say you got to get them sleeping. What are you doing? Are you using medication, or is it sleep by all means necessary? Or how are you doing the sleep piece? Because I would imagine that insomnia kicks right in for some of these individuals.
It does. So I'm going to say something funny, Kara, then I'll tell you. Okay. So if you want the 3 hour, I want the hour version of that, I'm giving a presentation on sleep at the Advanced Frequency Specific Microcurrent meetings in Chandler, Arizona in early March. But
okay, awesome. We'll link to resources as we can for you.
Yes, well, that's an incredible meeting anyway. But what I would say is I will often put people on low dose melatonin. I always tell them 1.5 hours before you want to go to sleep. I'll put them on blue light blocking glasses because I say, look, we've got to get deep sleep going on here. And then I set a bedtime. Of course, most people don't have a bedtime. Most adults, they don't have a bedtime. The kids say they have a bedtime, and then they stay up all night on their devices. So I'll limit devices and blue light and use blue light blocking glasses. And then, there's certain things that I'll do to encourage sleep. I'll tell people, look, I don't want you just lying there if you can't fall asleep. I want you reading. I just found that reading with a low blue light source is the best thing to put people to sleep. And I don't want them on a device within half an hour of that. And then I found a couple of homeopathic medicines incredible to get people sleeping, if you want to know what they are. One is Coffea crudea. Have you heard of that? It's actually fascinating. It's a homeopathic remedy related to coffee, but it stops a racing mind. So what I find with a lot of people after concussion or other functional medicine patients is they can't fall asleep because their mind's racing, they're worrying about stuff, but they wake up in the middle of the night, same thing. So I will have them take 5 pellets of Coffea crudea. And then there's also a product by Boron called Sleep Calm, which is a combination homeopathic, which I find works pretty good. I don't usually have to put people on trazodone. But occasionally, if I can't get them sleeping any other way, I'll either use trazodone or Lunesta. But I don't like doing that if I can get them sleeping normally. The other thing to help them sleep is get them physical activity during the day. And, in the morning, wake up and look at, the sky and the blue light in the morning. That could be helpful. But, and then no caffeine after 12 noon. There's a lot of things here.
Yeah, the usual sleep hygiene tips, dark room, cool room, and all of that, I'm sure, is a part of it. You had said you weren't going to get into pain, but I know that's going to be a question. Like, can you just give me an idea? Someone comes with a head injury and, they've got, I don't know, maybe it was a motor vehicle, but they come to you with pain and you said that that's got to be dealt with, immediately. Just give me a basic rundown of what you might be thinking about, instead of just leaving it empty.
Yeah. So, I do a complete neck examination, especially in neck and head, because a lot of times what I find is like trigger points in muscles that connect the head to the neck, and that creates headaches. So you can't always assume a headache is related to the brain. It may be related to a referred pattern. So I want to check for all the hypertonic muscles. And then I'll palpate the posterior joint capsules. I'll palpate the anterior muscles. And, I'll do spinal cord tests too, because I don't want to miss a spinal cord injury. So I do think it's really important to do that. But I think most of the pain that I see is coming from muscles and tendons and joint capsules in general. And then, I deal with that primarily with frequency-specific microcurrent because it works so quickly and so well. And because I find a lot of people, if they have too much pain, it's going to make them more fatigued and it's going to lead to them not sleeping, and we get to all these vicious cycles. So I do think it's important to control the pain. Now, if the neck's out of alignment, chiropractic can be really helpful, osteopathic can be really helpful, physical therapy can be really helpful. Those things can be helpful in terms of pain. I may even use a low-level laser, but most of the time I'm using frequency-specific microcurrent to heal the structures that are causing the pain, so we don't keep having problems with that.
What come to you on some kind of a pain management protocol? Like, are you wanting to? I'm sure you're wanting to transition them out of it, but
do you mean if they come to me already on a narcotic? Is that what you mean?
Yeah.
Well, that gets tricky because narcotics slow the GI tract. They decrease motility. And there's some information that narcotics lead to more pain sensitization. So I really prefer to taper the narcotics. The other thing is, a lot of people don't know that if you use frequency-specific microcurrent, you actually have to treat for narcotic interference with frequencies on channel 1 in order for it to even work. So, I really prefer to wean people off those medicines. I don't like them on those medicines very long at all.
I would imagine similar with non-steroidal anti-inflammatories as well. I mean, that's going to slow the healing process down also.
Yeah, I try to get them off those very quickly because, I think they can contribute to intestinal permeability, a GI bleed, even increased coronary events. So I don't want them on those drugs.
What does the diet look like?
What is the what?
What are you prescribing? What kind of a dietary pattern are you prescribing?
Oh, okay. I think I've got like a 3 or 4 page handout on the Healthy Brain Diet. I actually give it to people with cognitive impairment and concussion. It's based on a lot of issues. So let's just go through them, okay? There's all this information, and Aristotle Vujani developed a lot of this basic information on autoimmunity, molecular mimicry. So they're off of dairy and gluten for 8 weeks, whether or not they have an immune reaction to it, because the immune system will see certain dairy proteins and certain gluten proteins and go after aquaporins in the brain and other structures. And so in this diet, in this program, they're off of gluten and dairy for 8 weeks. Then I put them on certain either foods, or I say foods I want to increase choline because, not everybody's going to take phosphatidylcholine. I don't want them just relying on that anyway. But phosphatidylcholine is a good supplement for the brain in regard to building back neurological membranes. But you probably know that eggs are an incredible source of choline. So I have a list of all these foods that have choline in them, and I want them to choose from those foods, including, believe it or not, chicken. And then, so part of the program is increase your choline. Another part of the program is eat certain things that have, biochemicals in them that will help microglia shift from the M1 phase, which is inflammatory, and where they don't produce growth factors, to the M2 phase where they're more functional. So it turns out that the molecule apigenin is very important for that phase shift to occur. And guess what food has the highest amount of apigenin that we never eat? Parsley. I wasn't going to give you a chance to answer it because nobody can answer it.
I was going to say capers. Do capers have any? That's what Pat.
Oh, guess what capers have? Quercetin. Capers are the highest food source of quercetin. And quercetin has some effect on brain inflammation and in regard to the microglial shift. Apigenin and luteolin are the best, but quercetin has some effects. So I want them to eat foods with quercetin, like apples and red onions and the little green things that you just mentioned. Capers. And then, I want them to use parsley. Like I'll tell people, look, you take either a whole head of organic parsley or a half a head, and you put it in a smoothie with wild blueberries, because the wild blueberries have some kind of neuroprotective effect with the anthocyanins. Wild blueberries have more of the purple than the regular blueberries. I always tell people, look, you want the stressed out blueberries because they produce the purple pigment more. And so I'll have them make what I call a brain smoothie, which basically is wild blueberries and parsley, and then, plant-based protein powder that's organic, and then things to taste. And I'll actually ask them if they're willing to pour in phosphatidylcholine. So I'll have them get some liquid phosphatidylcholine to put into it. Then I'll have them make, if they're willing to make a brain pesto, I'll have them actually make a pesto that has mostly parsley and cilantro for the heavy mercury, and parsley for the apigenin, and then organic olive oil, no dairy, and basil. So if it, you can still put the basil in there to taste, and then they can put it on vegetables or anything. So that way they're going to get a lot of the apigenin that way. There's other things in the diet, of course, low toxin, mostly organic, non-GMO. There's other things in the diet, but those are the big deals.
Transition onto that. Let's talk about supplements. In the IFM, I deliver one of the lectures on fatty acids on fish oil, and I always bring up the handful of case reports in the literature where massive amount of fish oil was used. I want to talk about your supplements, and if you're thinking about very high dose amounts of fish oil or anything specific.
Well, I kind of know where that's coming from in terms of the very high amounts. But this is the way I would say, I have to prioritize the supplements for my patients because I try to identify what's most important, because sometimes I find if you have too many of them, they won't take any of them. The other thing I find, if too many things are in a capsule, they won't take them. Because a lot of people in functional medicine practices, they're already on 6, 7, 8 capsules. And so I got to think of things, okay, what alternative forms can get things into people? But I'm going to tell you what I think would be the most important supplements to think about for treating concussion and traumatic brain injury, okay? So one is in the category of neural inflammation, which I would think that you have to address in every head injury, in every stage of it, and chronic stages. And you've got to address that in cognitive impairment. I mean, you've got to address that a lot these days. So the probably most important supplement thereof would be a highly absorbable curcumin, because of all the mechanisms of action. I mean, one of the things is curcumin will activate the NRF2 gene response to activate endogenous antioxidants and anti-inflammatories. But the curcumin has to be in certain highly absorbable forms. And there's a number of studies. One of the forms that seems favorable is the Longvita form, Longvita, in terms of going into the brain. And the interesting thing about that is that there's a company that makes gummies out of it. So if you have a kid with a concussion, they're more prone to chew the mango gummies. They're called curcumin gummies. That's how I get the curcumin into kids. I don't find most people start swallowing capsules until like after at least 12 to 14. So I'd say curcumin is a number one thought in terms of neural inflammation. And then DHA and omega-3, but primarily the DHA component, I think is really important. I don't use megadoses of it because I usually combine it with phosphatidylcholine and a diet that's encouraging choline. Now, I will tell you this. If someone says, Doc, finances are not the issue, I will do anything. I'll actually put them on plasmalogens. You're probably familiar with Prodrome Sciences. I will use then, at that point, I'll use the plasmalogen neuro, and which you think of more for neurons, and then I'll use in the evening plasmalogen glia. I'll use the loading doses. But because those things are so expensive, I won't go to that initially. I'll go to the omega-3s. And I'll definitely use higher doses than I use for just like other issues. But I don't know that I'm going to go to these mega doses of, 15 to 20 grams. Then I think you have to start balancing it out with Primrose oil or borage oil or something. I just haven't had to do it. But I think sometimes in some of the cases you're probably talking about, someone was in the hospital, they didn't have access to microcurrent, they didn't have access to PC or whatever it was. So I would say that I do combine things, and by combining things, I'm getting the results that I want. And then I'd say another supplement is taurine, believe it or not, the amino acid taurine. And it has a lot of protective effects in the brain. It's pretty important right away. A lot of people don't think about it until it's important right away. It helps to regulate osmolar balance and, helps with decreasing edema, but it also helps with nerve stem cell survival. So it's good at any time. And I usually use doses about 1,000 milligrams twice a day. Another supplement that I find incredibly helpful is lithium, the mineral lithium, not the drug lithium, but primarily lower dose lithium. And there's so many mechanisms of action in the central nervous system that have actually been explored. Lithium was known for a while to have an effect on mood instability and anger, but it's incredibly neuroprotective. But I would tell anybody that is going to recommend this to a patient, you have to say, look, this is a mineral. We're going to use it in a low dose. You've probably heard of it for bipolar, where they use it for a high dose, like 600 milligrams. We're going to use 10 to 20 milligrams. And so the other thing is, don't go around telling everybody that you put me, that my doctor put me on lithium, because then they'll say, oh, well, you probably have bipolar. As long as I explain it that way, they don't have a problem with the lithium. I've never actually had anybody have a problem with low-dose lithium, except the perception of it. It's incredibly neuroprotective. I use it for literally every neurodegenerative problem, cognitive impairment, but especially for TBI. And then you start getting into specialty supplements, like supplements that will increase blood flow, like ginkgo. Okay, so that could be appropriate to increase blood flow. Then you start looking at, okay, how do I heal the blood-brain barrier? There is some information that glutathione is helpful for this. Liposomal glutathione we have to do, and high-dose alpha-lipoic acid. So I usually use the R form for that. I will say for every one of these jobs, I'm going to use frequency-specific microcurrent. I've developed programs to heal the blood-brain barrier and decrease neural inflammation, but I always integrate the supplements with the FSM if they can do the FSM. But I would say then we get into specific problem areas. Okay, do they need specific supplements to help them sleep? do they need like Bacopa, or are they having so much problem with their memory that I'm going to put them on, a number of things, specifically acetyl L-carnitine. I try to use I actually have a formula called Brain Memory that has most of what I want in it. And then there's another formula that has mushroom extracts and Bacopa. And I find Bacopa very helpful for the brain. But what I find is most people, you start adding more than 5 of these, they're not taking anything. So I always tell them what the top priority is. In the note, I tell them what it's for. I find the average patient will stop a supplement after a month if they don't know what the purpose of it is. So I'll say curcumin for neural inflammation, or lithium for brain protection, taurine for encouragement of survival of stem cells, that kind of thing. And then they're more likely to stay on them. And the other thing I think I told you at the beginning is I tell people, you're going to be on all these, unless I say differently, you're going to be on them for 3 months after you don't have any symptoms, which then encourages full healing.
Yeah, to come in. This is the journey ahead.
It's going to be a brain, you're going to create a better brain.
I think being, just really having as much disclosure on the program and the duration and all of that is incredibly important for getting, adherence. So you're seeing patients remotely. I mean, well, I guess my question, first of all, is if you're doing frequency-specific microcurrent, you're seeing them in office quite a bit.
Yeah,
but I know you're also doing...
I do telemedicine and I do in-office.
Yeah, so what are you doing in place of frequency-specific? Well, I get 2 questions. How often do you do frequency-specific microcurrent in office with a patient? I would imagine it depends on how acute the situation is.
I'll tell you, let's say it was that kid that was literally thrown against the glass. I mean, I was really worried. I've had a bunch of people I was really worried about. I've had kids that were in the neurointensive care in the hospital where the pediatrician and the pediatric neurologist said 90% chance you're going to have serious brain damage. Where at the end of my program, no brain damage, nothing, no symptoms, nothing. And, of course, then they go back there and they go, oh, I was, occasionally the neurologists will say I was wrong. They don't usually ask what they did. If they do ask what they did, they go, oh, I don't understand that. But if it's a bad injury, twice a week for 2 to 3 weeks. If it's less bad, twice a week for 2 weeks, and then once a week for 4 more weeks. And then every other week for 2 weeks, something like that. I like to go out to 10 to 12 weeks.
What are you doing with your remote patients?
Well, that's when we do one of 2 things. I get online and look up who, put their zip code into, find out if there's someone near there. And then I usually end up coaching them because there's only a few people that have as many brain programs as I've actually developed. And there's a few practitioners in the world that have developed brain programs, but the average practitioner doesn't have many of them. They have some of them. So then I have to call the practitioner wherever they are within 25 miles and say, what kind of brain programs do you have? Do you do it? How current are you? So if I can have them established with someone, I do. Otherwise, I will program a microcurrent unit, we'll mail it to them and train them how to use it. It is. Yeah, I started using it in 2009, and my results for the brain were significantly better than before I started training in it.
That's extraordinary. I got to shadow Dr. Carol McMakin.
Yeah.
When I was a student, and I just consider her a mentor and adore her. And, it was quite an honor to be able to see the work that she did and some of the patients that she just turned around in an extraordinary way.
Yeah. And since you were shadowing, it's gotten much more sophisticated and advanced. In terms of treating the brain, it was very early back then, when you were shadowing, but now it's gotten extremely sophisticated because, it's a 2-channel microcurrent system. The first channel is the conditions. So we've gotten even more sophisticated in terms of channel 1 frequencies, because they're actually channel 1 frequencies for virus, for mold biotoxins, for toxins and metals, and even the COVID. And so we got more sophisticated with that. And now we've got protocols for the vagus nerve. So you can actually restore the vagus nerve and get it back functioning again, as well as you can treat the blood-brain barrier and the GI tract and augment treating permeability. So yeah, I do think it's extremely important if a patient can get this treatment.
I want to do a case, but before we go into a case, give me what kind of labs you're doing. And, given the gut involvement that you routinely see, are you doing a stool test? I mean, what kind of labs are you doing?
I think it depends on the symptoms. Like, I would say the labs would be more common in the chronic stages. Past 8 to 10 weeks, they're still having symptoms. I'm going to do, sex hormones. I want to know, because I've seen all kinds of things. I've seen low antidiuretic hormone. I've seen thyroid disorders, because you can have pituitary injury. So I want to run those. I may run a heavy metal challenge test. If there's any suspicion of mold biotoxins, then I'll run the mold biotoxin labs. There are specific tests for something called S100B. It's an antigen from the brain and the blood-brain barrier. So Cyrex Lab does that, LabCorp does it, ARUP Labs does it, and Vibrant Labs does it. Vibrant Labs does more blood-brain barrier testing than anybody else. They actually even have an antimicroglial antibody test, a number of things. So they have a basic test, which is called NeuroZoomer, and they have another test called NeuroZoomer Plus. The NeuroZoomer Plus is almost like a Cunningham panel or more, with a lot of brain autoantibodies. And so I will run that. If I think someone's got a lot of issues, I want to know, do they have brain autoimmunity? And then sometimes I'm going to run Epstein-Barr panel, because I've had people that have cognitive dysfunction a little too far into that head injury, and I want to know, okay, did they have reactivated Epstein-Barr? I will run a CRP. I'll run an anti-nuclear antibody. And of course, I'll run a regular hematocrit. I'll run iron studies. It really depends on what the other problems are.
Why don't you give me a case that comes to mind? Maybe one of your, I don't know if you want to walk us through this boy who was like checked into the wall playing hockey or something, or another one that comes to mind.
Yeah, the other one is quite similar. There's a lot of them. So the other one is perhaps an even better case, because it was a 14-year-old that so he was riding his bike. If you ever go to Boise, you want to, if it's not winter, you want to ride the Greenbelt Trail, because the Greenbelt is this 25-mile trail along the Boise River. It's quite scenic. Anyway, that puts Boise on the map, because you and I were laughing before we started about some people don't even know where Idaho is. If you asked them what's a city in Idaho, they wouldn't know. And I must state that before I moved here 3 years ago, I didn't know either. I thought Boise was here, and it is. But anyway, so there's a part of the Greenbelt Trail that you can go off on the side and do some little mountain bike things. This kid didn't have a helmet on. He did these little mountain bike things, and he fell over and hit his head. He lost consciousness, and they brought him to the emergency room, and he had a brain bleed. So this is an actual example of a more serious head injury, but I want to give it, not that everybody's going to see these brain bleed cases, but it's important. So he was in the hospital for a number of days. They actually did an operation, and they evacuated the brain bleed, and then he was in the hospital, and they weren't doing anything in the hospital, really, just lying there, sleeping, eating. And I'm telling you, you don't get very much sleep in the hospital. So they contacted me, and I said, look, if he's stable, you got to get him out of the hospital and in here. Now, this is the case where I told you that the pediatric neurologist said, pulled the parents aside and said, we're really sorry, but we've done what we could. Your son is going to have serious brain damage. And I don't know why anybody tells people this. He probably won't do well in school. He probably won't go to college. I mean, the whole thing. And then, and the parents said, well, give us a percent on that. They go, 90%. That was that one. And so I evaluated this teenager when he got in here. He didn't look right. I could tell something was wrong with him. He wasn't creating words well. So he had a problem and broke his motor street. He couldn't find words. His short-term memory was not working well. He had problems with focus of attention. He couldn't, really function very much in school. So they just took him out of school for a while. His brain energy was really decreased, and he was having trouble sleeping. And he was having nightmares and all that. So that's when he, came in. The brain region localization showed problems in almost every area of his brain. And so that gives an interesting thing here, that you could have a brain bleed and then you could have like larger areas involved. So what we started doing, I think I got him like 7 to 9 days from the event. So he was having headaches, dizziness, nausea. So I forgot to mention that there's a really interesting homeopathic medicine that sort of has a good effect on a lot of post-concussion syndrome symptoms. It's called Natrum sulfuricum. So, I evaluated him. His balance was also off, so I knew there was something wrong with his cerebellum. So I used some of the methods that I already talked to you about getting him sleeping. They got him some blue light blocking glasses, got him to stop using any kind of iPad or anything after 9, and got this kid sleeping. We did use coffee acrudia and the sleep calm with him. And then I did put him on the gummies, the curcumin gummies, because his mother already said, he doesn't like swallowing things. And so I put him, because it was serious, I put him on liquid phosphatidylcholine. And, we gave him the diet, and said, look, load him up on eggs and, let's start making the brain smoothies with the wild blueberries and the parsley. He went on the curcumin. I put him immediately on the low-dose lithium and the taurine. And some of these they just emptied out. Some of them he was willing to swallow. I did put him on high-dose DHA. And we immediately started frequency-specific microcurrents. So we started.
What's high dose for the DHA?
Oh, I put him on most of the DHA capsules. You're lucky if you can get 500 milligrams in a capsule. So I put him on 3 twice a day. And then the phosphatidylcholine, I had him on at least 1 gram to 2 per day. I had him continue on the Natrum sulfuricum. And then he was in for frequency-specific microcurrent, initially doing what we call this, I have a basic concussion protocol that I'm not going to go through all of them, but you have to sequence this. You have to treat the blood-brain barrier. You have to treat for neural inflammation. So I did all that with the programs that I designed. Also, his vagus nerve was not working well. He was having GI problems, and he was kind of constipated. So I started also treating the vagus nerve. I had him do high-intensity gargling to try to get the vagus nerve work better. And then we started getting him exercising as soon as he could, because a lot of people don't realize this, but rest is not good for the brain. Sleep is, but not doing nothing. And so getting someone to do some cardio aerobic exercise without headaches is important. So we started getting him doing that. To generate brain-derived nerve growth factors.
Like ride a stationary bike? Or
ride a stationary bike, ride a regular bike. This was during the summer, so we could ride a regular bike. And just get his heart rate up 30 to 40 minutes. And, just gradually he progressed to the point where the brain region questionnaire had all zeros. Nothing. And then you ask this kid, his personality was weird initially because it was dull. And his parents said, he's not acting like my kid. But eventually when I said, okay, you're done, but you're going to take these supplements for another 3 months, his personality was totally back. He started laughing. Everything got back to normal. And we made sure that school is normal. Now, I'm going to tell you about something else that's rather interesting, that there is a type of treatment. Oh, I got him in hyperbaric right away as well. I forgot to say that. I don't usually need 20 sessions, but sometimes even 6 to 10 sessions. That's fine. They don't need 20 necessarily if you're doing everything else. There's a treatment called audiovisual entrainment, which is really interesting because what it is it's light stimulus, sound stimulus, and it entrains the brain to go into certain brainwave patterns. This kid could not focus for a while, so we used audiovisual entrainment. The nice thing about that is that some of the systems are very inexpensive, because if it works and you want them to use it for a half an hour, if they have trouble focusing, it can help sleep, focus, and mood. That's the way I would say it. So that can be very helpful too. And so the kid, got back to completely normal. They did go to a neurology appointment just to go and tell the neurologist that I want you to know, even though you said, they said this in private, even though you said 90% chance he was going to have serious brain injury problems, wasn't be able to do school, wasn't going to be able to do sports. They said, my kid's completely normal. And then the neurologist said, yeah, apparently he is. So, they did at least go back and tell the neurologist that. At some point, I actually would like to give a talk to the pediatric neurologist in the group, because I think they need to know about this, because I don't think it's okay to say 90% chance your kid's going to have serious brain damage and we don't know what to do.
No, it's terrifying just listening to you say that as a parent. Yeah.
But what I would say is, this is a case of a serious head injury that was taken from serious brain symptoms, serious personality and mood, to normal everything. But what I would say is, it went smoothly because I have the frequency specific microcurrent and all that. I have the audiovisual and treatment equipment. But, then it gets complicated when you got people that aren't resolving after 12 weeks, and then you really got to put your functional medicine thinking cap on and think about all these comorbidity issues and what you might have to do, checking the viruses, checking the hormones, checking all this stuff, what you might have to do to really improve things. And I always tell people, I say, there's room for hope. It doesn't matter how many head injuries you've had. It does bring up another point that I want to tell you. Where they have the dysfunction, like word finding, let's just use that. You have to challenge them on a daily basis with brain exercise, because what you need in order to create synaptic networks is BDNF plus brain challenge. And then you're going to get the synaptic networks and the branching. So almost every one of my patients gets specific brain challenges to do. We try to make it fun. For the people that are having trouble with memory, they just do the animal matching card games and the Simon game. So there's a whole range of these brain challenges you got to do with people to complete the program.
Listen, we're at time, but this has just been a great conversation. It's just really nice to talk to you after I don't think that I've seen you in person for a while. Were you at this year's annual AAIC? Were you at the AAIC?
No, I haven't. I don't think I've been. I'm not sure if I've been to the IFM. I used to speak every other year at that, but I don't think I've been since COVID.
Right. I don't remember seeing you, and we would have had at least a few minutes chat where I know you would make me laugh, as you have for forever. Well, thanks for coming, David, and just sharing your brilliance and your hope. I love how you've looked at this. You've shaped it through the functional lens, but then you've got some serious expertise. We will, on the show notes, my team will reach out to you and kind of pick your brain to get access to your website and, any references that you think are important in your books and so forth. So I'll circle over to the show notes, folks, on the website to access all of it. And, again, thank you.
Yeah. And then if there's a clinician that ever needs help, then I can do a peer-to-peer with them.
Awesome.
Guide them through that.
Great. And then you do telemedicine, and then you also do on-site. So yeah,
right.
You're an awesome resource. Thanks so much.
Okay. Thank you.
As always, thank you for listening to New Frontiers in Functional Medicine, where our sponsors help bring you the very best minds in functional medicine. These are brands that I know, I trust, I use in clinical practice, and I can confidently recommend to you. Disclaimer. This podcast is for informational purposes only. If you have a specific medical concern or if you have any questions, please speak with your healthcare provider.